For joining us. Hi, everyone, and thanks for joining us today. This afternoon's Hangout is going to focus on ONC's shared nationwide interoperability roadmap and why the innovation community should get involved with ONC's work to support an interoperable learning health system. We're going to be hearing from Erica Galvez, ONC's interoperability portfolio manager, and Morgan Reed, the executive director of ACT, the ACT Association. Erica has spent the last several months tirelessly leading the effort within ONC to work with both our federal partners and external stakeholders to develop the content of the roadmap. Thank you, Erica, for all of your hard work. And Morgan's been incredibly active in helping to bridge the divide between the innovation community and the federal government. You can learn more about his organization's work around health technology at healthismobile.com. Just one quick housekeeping note. After the discussion, you'll see we have some time at the end for open Q&A with the audience. There's a little Q&A button in the Hangout window that you should be able to use to queue up any questions that you have that come to mind as Erica and Morgan are talking. Or if you, for some reason, can't get that Q&A app to work, feel free to leave your questions and comments on the Hangout event page itself, and I'll be sure to bring them up at the end. So with that, I'll go ahead and give Erica the chance to briefly orient us with how the roadmap is structured, and then Morgan's going to get us started with discussion. So Erica, over to you.
Terrific. Thank you, Maya, and apologies in advance to everybody for the lighting in my office. There's little I can do about the window behind me, so I thank you all for tolerating it. As Maya mentioned, I serve as the Interoperability Portfolio Manager at ONC, and with a really talented and dedicated group of folks have been working on pulling together what is now out for public comment as the Shared Nationwide Interoperability Roadmap. To give a little bit of context before we dig into some of the substantive discussion, I often find it helpful to define interoperability so that we're all talking from the same base as we've gone through this exercise of setting a vision for interoperability and then mapping out a path forward around interoperability. I have found that the term actually means different things to different people. And so it is sometimes helpful to set the framework with the definition. So ONC defines interoperability as the ability of a system to not only exchange information with other systems, but to be able to use information from other systems without special effort on the part of the user. So according to that definition, simply moving information or exchanging information between systems doesn't really get us to interoperability. That's certainly a first very important component, important step. But we have to add on to that the ability of the system to basically be able to process and parse the information so that it's usable for users. And that needs to happen in a manner that doesn't require special effort on the part of the user. So does not involve things like manual data entry, as an example. We find ourselves at a time now, some people have asked, why a 10-year interoperability roadmap at this point, and why not focus on near-term actions? A couple of thoughts that I'd like to share contextually around that. First, as we think about interoperability as a support mechanism for achieving the three broad aims that the nation has put forward through the National Quality Strategy, these are a focus on improving our population's health, spending our healthcare dollars more wisely, and improving our care delivery system from both a quality and a safety perspective. We need to think about the opportunities that health IT provides to move information when and where it's needed, and as I mentioned earlier, in a manner that's actually usable by the user. If we think about the fact that the average Medicare beneficiary sees 2 primary care providers every year, plus 5 specialists, we see tremendous opportunities just for the average person to better coordinate care across the care delivery system using health information and technology as a tool to move the information. If we think more broadly about supporting that population health goal, this notion that we want people to be healthier, we actually have to start thinking beyond the care delivery system. We have to think about how people use information on a daily basis and the technology tools that can support their use of information. This isn't just from a consumer or person-oriented perspective, but also relates to our research communities, to our public health communities, to a broad range of human services and other societal supports that wrap around a person and support them. And so we've approached our vision for interoperability for the next 10 years and our interoperability roadmap with that context, thinking very, very broadly about an ecosystem that includes the care delivery system but extends well beyond it. The vision that we've put forward and the reason we set this 10-year time frame is we think it is well worth working towards the notion of a learning health system. This is the concept that was put forward by the Institute of Medicine many years ago, has evolved some since the initial material that was put out by the IOM, but holds very true to the fundamental underpinnings of the concept, which relate to closed information loops that support evidence generation and the use of evidence for decision making. And so that extends not only into our research communities and our care delivery system, but as I pointed out a moment ago, it basically becomes the everyday stuff of everyday decision making by people, by consumers. To achieve a learning health system, these closed loops of information flow at multiple levels of scale nationwide. Our context here is nationwide interoperability. We think that will take about 10 years. And to be candid, I think that's ambitious. I think 10 years is ambitious. Not impossible, but it will be challenging. We've actually set our sight in the near term on some very specific milestones that we think put us on a path toward the learning health system, but help us achieve some very important outcomes to support those three aims that I mentioned in a much shorter time frame. So for the next 3 years, we've set our sights on achieving the ability for the majority of providers and the majority of consumers to be able to send and receive, so basically push and receive, find, to query and retrieve, and use, be able to use in a manner they need to, a common clinical data set. And we've focused on those discrete actions and a discrete set of data because we have found as we go through this interoperability journey, we have to start getting very concrete about what it is, what information is going to flow, what functions need to wrap around that so that our system can build to support both the information sets and the support functions. As we pulled together the interoperability roadmap, I do want to mention that we have gathered input from a number of different sources. We actually launched an online community forum several months ago and asked for input at the very beginning of our development process. This was shortly after we released an interoperability vision paper, but before we put out draft material for the interoperability roadmap, that input was tremendously helpful. We've pulled together a series of subject matter experts. We have spoken with state governments. States play a very important role in enabling interoperability, so we've had very targeted convenings with them. We have worked with other federal agencies, we call them federal partners, through a number of different venues, including what is called the Federal Health Architecture, and at this point have wrapped all of that feedback along with a process that a core team went through to define the functional and business requirements of a learning health system. And that is basically the structure of the roadmap. So you'll find in the roadmap, we start with 5 interoperability building blocks. And I'll give you a sense of what those are. And then within each building block, we have organized core functional and business requirements for a learning health system. Then within each of those sections, you'll get some background on the area, looking forward, what do we think needs to happen for that given topic area, and then a set of critical actions. These are the things that we believe need to be carried out, and generally those are assigned to different stakeholder groups. Those may be assigned to federal government, they may be assigned to private sector actors, they may be assigned to state governments. It varies by the section of the roadmap. We did that very intentionally because we don't think this is a job just for government. We don't want the roadmap to be just an ONC, an HHS, or a federal government document. It's really a document that is shared across the entire ecosystem as a map for the path forward. So very briefly, 5 building blocks. The first 2 deal with technology itself. The first is core technical standards and functions. These relate to not only things like content, so vocabulary and format standards, transport, security services, but also core functions like accurate identity matching. Some folks refer to it as patient matching. Functions like resource location. We do have discussion in that section of things like provider directories and the role that those can play in the very near term in enabling and helping advance interoperability. The second building block is focused on certification to optimize products and services. In this section, you'll find that we do discuss ONC's certification program. I'm happy to talk about that in a little more detail, but also recognize the need for testing tools, actually a broad suite of testing tools that extend well beyond a certification program, whether that's ONC's or any other certification program. We've included that in the roadmap in large part because we have found that after technology goes through the certification process, it gets installed, it gets configured locally, and there are a number of things that can happen during that implementation process that end up breaking, quote-unquote, interoperability. We think testing tools that wrap around the technology outside of certification can help address some of those issues. So if a developer or even a provider or a consumer who purchases technology, they implement it, has an opportunity to run a test of that technology to see how well it interoperates with other technology, and that test can then pinpoint where a problem is to help problem solving. That is something actually that someone can back to the technology developer, or if the developer is using the testing tool, can actually use to troubleshoot and resolve whatever the barrier might be. So important discussion within that building block that I want to make sure folks are aware of extends well beyond ONC certification program. The third building block is focused on privacy and security. Certainly components of that relate to standards for technology, but a lot of policy pieces in that section also related to not only things like encryption, but I'm sure as people are interested in topics of permission or consent, authorization, authentication, etc. The fourth building block is focused on environmental factors. These are, again, environmental things that wrap around technology. So not only our business and regulatory environment, but also the clinical environment, and frankly the cultural environment. There's a lot of cultural factors some of you may recognize have an impact on interoperability. And then the fifth building block is focused on rules of engagement and governance. This isn't just about the notion of having a set of common or shared rules by which all data trading partners abide, but it's really also about having a process for shared decision making, a place, a venue where folks come together, they make shared decisions, and also establish mechanisms for accountability. We found that this is another very, very important component of reinforcing interoperability and really enabling it in the first place. Then there are a series of appendices. I can talk a little bit about those. All in all, the roadmap is a little over 160 pages. It is quite lengthy. It is well worth a read, though, and if, in fact, if folks can't get through the entire document, don't have the stamina or the interest in going through the whole thing, I would recommend taking a look at the table of contents. There's a pretty decent one at the beginning of the document. See which sections are relevant to your work or interesting to you, and take a look just at those sections. It is posted on healthit.gov. The public comment period is open until 5 p.m. Eastern on April 3rd, so there's still a good amount of time to download that and take a look. We welcome comments from anyone who wants to take the time to read the document and send us feedback. And so with that, maybe I'll pause. That's quite a bit to digest, and see if Morgan, you want to tee up some questions and discussion.
Well, thank you very much, Erica. Hopefully I'm live. Maya has the control. I think you did a good job of outlining all of the aspects of the roadmap writ large, but for our members and ACT, for us, we represent 5,000 companies spread throughout the world, but through our Connected Health initiative, we've got dozens and hundreds of companies that are trying to figure out how to change patient outcomes through interaction with EHRs. And we're finding that a lot of the problems that we face come from basically a problem of misaligned incentives. That we find ourselves in a situation where we see a way to improve patient outcomes, but we don't have the access that we need and more of the interactivity. So I like that this roadmap takes that question on a bit head on. Pardon me for the alarms, it's always DC. But in a nutshell, you know, what we're looking for is, how do you see this roadmap making economic sense for all stakeholders? What are the new requirements and new penalties that you mention throughout the document that should help to better align incentives? Because I think that will be the most important element to making this roadmap something more than merely an exercise in thinking about the problem.
Yeah, thanks for that, Morgan. It's a really good question. So one of the things that we give some, maybe two thoughts related to this. One of the topics we give some attention to the roadmap, and in some detail, is the policy levers that in one sense depend on interoperability to be successful. These are things that relate very closely to value-based payment models, for example, but also create opportunities to really encourage interoperability. And many of those business drivers exist at the federal level through not only CMS payment policies, but if we think about things like the Department of Defense EHR acquisition and the requirements that are currently built into the proposals that they're reviewing, huge room and huge opportunity there to reinforce interoperability, and I think the kind of data flow and integration that you're talking about, both out of their systems and into their systems in a bidirectional manner. The roadmap does deal with federal policy levers along those lines, state policy levers. Let's not forget there are lots of activities that happen at a state level that create the right type of environment for information flow, and then a number of opportunities in the commercial sector with commercial payers, but also purchasers, organizations that purchase care coverage, healthcare coverage for employees. The other note that I would make related to that is we do focus, as you said, we do kind of take head on this notion of it's not okay for information to flow just one direction. It's also not okay for information to just be exchanged and not be able to be parsed and processed in a manner that's useful. So we can talk a little bit about some of the strategies that we have in the roadmap if that's of interest.
Yeah, I think it might be worth drilling down a little bit, and you just touched on it, which is the concept of, you know, what happens if you don't make interoperability happen with your EHR, and how does that reflect an economic urge that will really put a lot of these new companies that are trying to enter, and frankly some of the big companies, in a better situation to do what you just mentioned, which is exchange. So, just in a time box sense, tell us a little bit more about penalties is such a negative word, but how do you view the discussion that you have in the roadmap a little bit about requirements and penalties, and how you guys see that framing out, but also on the good side is, how does doing a great job with EHR likely to have us an increased economic benefit for companies that are trying to make it happen?
Sure. So I think most folks are probably familiar with the Meaningful Use program. We talked a little bit about not only the incentives that are part of that program, but we're moving into the penalty phase also, right? And so there will be some financial penalties that eligible providers experience due to a lack of achieving those meaningful use requirements. There is also, I think, hopefully folks are familiar with the announcement that was made by the HHS Secretary toward the end of January, focused on shifting a certain percentage of the current, not only fee-for-service care, but other types of care that CMS covers, into value-based programs. And programs focus on paying for outcomes as opposed to paying necessarily for quantity rather of of care. Now, to get to a point where a provider is making decisions that drive quality and drive outcomes and don't necessarily drive volume, they have to have information from multiple sources. There's just no way around it. And in order to achieve that efficiently and in a cost-effective manner for a provider, I mean, all the pointers point to interoperability. The health IT has to reach a point where, again, information doesn't just flow, but it feeds into tools like clinical decision support, right? And so providers have information and can apply it at the point care.
Well, so that's
thinking a little bit about.
Yeah, I think that's
Sure.
a good place to put a stop for 1 second, because it sounds like you're saying, and I know you are, having read the roadmap, I think you guys are taking very seriously the idea that you want to put a thumb on the scale, both economically and policy-wise, towards getting more interop. But that raises a good question about the differences role that CMS plays from ONC. And I think a lot of folks in the industry are not really sure how those two things are going to happen, and what does it mean, because ultimately we want to make products that change patient outcomes and really engage with care teams. We got to figure out who's in charge and what are we looking for from both ONC and where does CMS fit?
Sure. Yeah, you're absolutely right. So ONC doesn't control any of those financial penalties or incentives. That's something that, if it's not clear to folks, hopefully I can clear that up. Now, in fact, ONC's primary role is to serve as a coordinator, right? We're the Office of the National Coordinator, bringing different components of the health IT ecosystem together to work better and serve customers more efficiently and in better ways. We do have a couple of other levers on the ONC side that folks may be familiar with, including our certification program. So ONC does run a certification program. It has thus far largely focused on making sure that the technology that goes through certification is compliant with certain technical standards. There is room, and we do discuss this in the roadmap, to advance some of those aspects of ONC certification program to really focus on interoperability. And that's something it's a lively part of our discussion in an ongoing way. CMS, on the other hand, really controls the payment policies around Medicare and Medicaid. Medicaid at a federal level that really gets, there's actually more control in that sense at the state level. Nonetheless, any payment, anything that's tied to financial incentives or penalties, again, that are payments in nature or financial in nature, are going to be coming primarily through mechanisms like CMS. There are some federal agencies that have some enforcement authority that can kick in some areas, like FTC, for example. But the nuances of when and where those apply get a little bit sticky. And so I think it's important to recognize CMS as kind of the reinforcement mechanism. Their payment policies can point to ONC certifications, and ONC really has a role in coordinating with the health IT community and then offering tools like the certification program to reinforce the performance and optimization of that technology.
So it's probably an overstatement to say ONC is the carrot and CMS is the stick, because depending on the situation, it can be either way. But it's good to know that you guys are working with CMS in a way that clearly states interoperability is important. But that's actually a really interesting thing. You opened up your talk about the fact that interoperability has multiple meanings, and one of the things that's always driven a lot of our folks crazy is that the first iterations of EHRs were oftentimes allowed for data portability, but were not truly worthy of the word interoperability or meeting that idea of exchanging data, meaning in and out. You might be able to take one EHR and move it to another EHR, but making the two meet was quite difficult. You specifically call out the concept of exchange of data in the roadmap. In just a few short sentences, how are you guys thinking about the difference between portability and data exchange?
Yeah, that's another very, very interesting question. So one of the things that we really push on in the roadmap is this notion of semantic interoperability. really defining, this is part of why we've defined a common clinical data set, and focus on a core set of data elements to get to a point where we're not just talking about exchange, moving a flat file from one system to another, but really being able to, as you said, can integrate the data in useful ways. We have to be able to parse the data. And that requires some definition at a pretty granular level, so that a sending and a receiving system, the meaning is retained, essentially, right, of the data across the system. We focus fairly heavily on that in the roadmap through our standards section, and thinking about how we apply standards across a number of different technologies to really advance that notion of semantic interoperability.
I think that's good, and I know we've talked briefly about this, but for those of us in the tech industry, the concept of going to REST and JSON is old hat, but just a little bit. This is a concept that you're really trying to introduce and drive home. You want to talk briefly on why you guys, welcome to this century, but what are you thinking about that?
Yes, yes. So we do also, I'm glad you raised this one also, we do really embrace in the roadmap this notion of leveraging RESTful APIs or application programming interfaces to create an environment where interoperability is more scalable and more nimble, allowing for the query and the retrieval of very precise pieces of information as opposed to these lengthy, heavy clinical documents that our technology has been focused on largely in the past. I think you asked a little bit of the initial part of your question was about one of the guiding principles that we put forward in the roadmap related to building on our existing health IT infrastructure. And there have been many questions about, and I would say many debates in some respects, about whether it makes sense to build from what we have or kind of rip and replace what we've got with something that's more nimble and perhaps a little more modern. In having many different conversations with many different stakeholders, we landed on that guiding principle primarily because it seems to us that we are going to start much farther down the road by building on the investments that have already been made and updating those technologies, evolving them, recognizing that they're going to evolve at a different pace in different settings, but making this transition that you mentioned toward a more restful environment over time. One of the other guiding principles that we put forward in the roadmap is this notion that different segments of the health IT ecosystem will advance at different paces.
Right.
And we need to be able to accommodate that.
Yeah. In fact, actually, that's one that a lot of developers find very frustrating, which is that the standards oftentimes dictate, frankly, just atrocious user interfaces. That there's this feeling that the engineering behind interop becomes the engineering behind what we call UX or UI. On page 20 of your document, we talk about those guiding principles on this one size does not fit all. Break out for us, quickly, what do you think about this difference between UX, UI engineering and experimentation in that segment versus interoperability and where you're trying to drive everybody towards a common framework?
Yeah, one of the things we have learned, we've learned it in a number of different venues, but particularly around stage 2 meaningful use and the rollout of technology to support providers through the second phase of meaningful use, is that there, for some reason, has been this sense, and I think, Morgan, you touched on it, that because something is standardized in the back end of a system, then it somehow has to impact how the user experience or the user interface is tailored, and in many respects is not tailored to the needs of the user. We put forward the guiding principle that one size does not fit all for that very reason. We want to make it clear that tech developers should be listening to the needs of their customers and their users. They should be tailoring the user experience and the user interface to the needs of those users, and we think that's very possible, even though certain components will have to be standardized, again, as I say, in the back end, in order to make interoperability possible.
Well, Erica, you're painting a very rosy picture, but this brings up something that unfortunately drives a huge portion of health IT and experimentation in this space, and that's liability. Unfortunately, we often find ourselves experimenting with great UIs, great UXs, great data stores in the cloud, a whole collection of different things, and yet we'll run into a care facility's risk assessment officer, and they'll say, yeah, no, we won't bring it in. Either questions about HIPAA or questions about how things are moving. In your document, you talk about respect policies for other exchange partners, and you touch briefly on this concept of not using HIPAA to obstruct patients, patient advocates, patient-mediated exchanges from getting access to that information. But on this, I want you to take a few moments and really talk about where you think there's some failures on both our community and, let's be honest, with the care community to understand where HIPAA extends and where HIPAA is frankly becoming an impediment to good care.
Yeah, you're right. We do call this out explicitly in the roadmap. We have seen HIPAA used as an excuse in some cases to prevent information sharing and information flow. Sometimes I think that's intentional, and sometimes I think it's unintentional. I think there is a lot of misunderstanding about the framework that HIPAA and HIPAA rules put forward, and that gets translated many times over. So HIPAA is a federal framework, and we talked in the roadmap about the need to clarify for folks exactly what that framework is. That doesn't mean changing those rules, but it means educating communities so that everybody has a common understanding of what that framework is. What we see in the environment today, which I think you're pointing to, Morgan, is states tend to layer on top of HIPAA additional constraints or requirements around information sharing. And we tend to see, even at a sub-state level across organizations, then additional requirements that may be layered on top even of state policies, right? And so it creates this patchwork that's really difficult to navigate, not only as a person, but we have found through some of our studies that it's hard for our technology to navigate in any automated sense. And so one of the things that we are pushing for and asking really the community to get on board with is, one, really understanding HIPAA and how HIPAA, in many respects, supports interoperability, enables interoperability, and abiding by that framework.
So, but let's stop for 1 second. Talk a little bit about that. How do you see HIPAA enabling interoperability? How would you like us, when we walk into a meeting with a care facility or a care team, and the lawyer in the room says, yes, 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 but what about HIPAA? Where are the places that we should point people to graciously, obviously, because they're our customers or our care providers? What are the places that we should direct them to say, well, actually, here's how HIPAA fits with this?
It's actually a topic that's maybe ripe for an entire additional Google Hangout, and I think our Chief Privacy Officer would be ripe for hosting that. I will say, I would suggest starting that conversation by pointing to the permitted uses in HIPAA. HIPAA outlines a framework for permitted uses. It outlines the notion of exchanging information for treatment, payment, and healthcare operations. Now that healthcare operations bucket is maybe a little bit nebulous, but there are very clear parameters around information exchange and use for treatment purposes and for payment purposes. There are also very clear parameters in HIPAA that relate to a person's right to access their own health information and the obligations of healthcare providers to make that information available to them. And HIPAA actually, OCR, the Office for Civil Rights, has offered even some recent clarifications around that.
Well, we're hopeful that there will be additional clarifications around some of that and better guidance. Unfortunately, oftentimes we're stymied not by the facts, but the absence of information in some cases.
Agreed.
That's something that we all know that has to be worked on, and hopefully we'll see at least some clearer information on that. I think that's helpful. I think we definitely can spend more time on HIPAA, as you said, because unfortunately it becomes such an odd and confusing barrier for something that really should be an incentive. But on that same note, you know, on page about 112, for those of you playing at home, you talk about measurement actions. Talk a little bit more about how you want to measure interoperability, What are the measurement actions that you take? And then throughout the document, you make requests for stakeholder input. Why don't we talk a little bit about that, and where do you see that working, and how do we actually get involved or stay involved and know that what we're doing has an impact? A lot of folks feel that we send stuff to the federal government and it kind of disappears. Unless it's our tax form, it kind of just disappears.
Yes. Another very, very good question. Actually, several questions in there. I'll try to parse a little bit around the measurement piece. We actually put forward a measurement framework. We know today we don't have ideal measures of interoperability. We don't have ideal data sources to feed those measures. So we put forward a framework that suggests we should measure not only technology capability, but the usage of technology and the impact of technology, both from a process and an outcome perspective. In the near term, we're going to have to use the data that we have and the measures that we have. So these are generally measures that relate to provider feedback through things like the American Hospital Association survey, the National Ambulatory Medical Care Survey. We certainly have meaningful use data that we can take a look at.
Well, Amy, what about, I'm sorry, Erica, what about looking at some of the patient data, some of the input coming in from, we know we need to have it from the EHRs as well, but is that an area where patient groups, patient advocacy group, patient-mediated exchanges, some of those folks should definitely, I mean, do they have an opportunity to be a stakeholder in this?
They are absolutely a stakeholder in this. We actually run a consumer survey, and that's another one of our data sources. In terms of, so that's what I'm thinking of, at least from kind of a quantitative measurement perspective. In terms of getting involved, providing input in an ongoing manner, ONC has a number of activities that go on at any point in time that I would encourage folks to engage in. We actually have an Office of Consumer e-Health that focuses on consumers and their use of technology, digital health literacy, all of those different components that are very important, and there are avenues to get engaged there. We can point folks to some resources on the website and other opportunities for folks who are really interested in the technology piece of this and some of the more technical components. We have the Standards and Interoperability Framework, which is a community-driven forum for really curating technical standards that end up in places like our certification program. So a number of ways that I would really encourage folks to get involved. And as I said earlier, the feedback that we get on the roadmap is something that we take very seriously, and we will be incorporating into an updated version of the roadmap that we'll put out in the summer. And so I would encourage folks to provide input through that avenue also.
Okay. One of the things that you started out earlier saying if you can't make it all through all 166 pages, you'd understand, but at least read the table of contents. Having read all 166 pages and done my crosstabs, I wanted you to spend a little bit of time talking about how you think we should use the appendices. There's more than 50 pages of appendices in this document. What are your goals with those, and how do you want us to implement things in there? And what's the upside for us? How should we be taking them? And what if something in those examples in the appendices doesn't make sense or doesn't work? Where's the right place to start providing feedback on that?
So to the feedback question, healthit.gov, we have a page up for folks to provide input. If you have feedback on specific pages or specific examples, components of the appendices, please send those very specifically to us. Identify the page and the specific area where there's an issue. You're right, we have a lot packed into the appendices of this document. If you're looking for concrete examples that relate to specific things like medications or certain care settings like long-term care or behavioral health, you'll find many of those examples in the appendices. We did that in part because the core component of the document was getting so long and difficult in some cases to navigate. We also leveraged the appendices to try to define concepts and terms throughout the document, so that's another important resource there. You'll also find, for some topics, some significant background in the appendices. And so That's another place if you're looking for context, for example, on consent and how we have arrived at kind of the policy framework that currently exists for consent. You'll find that in one of the appendices at the back of the roadmap.
So do you see the appendices as something that will change over time? Because it's interesting. If we think back of the technology of 10 years ago, 10 years ago we didn't have the iPhone, we didn't have the smartphone revolution, we didn't have the tablet that I'm using right now to do part of this Google Hangout. And so a 10-year roadmap for interoperability is awesome on one sense, but it's awesome in the actual meaning of the word awesome. It is a bit awe-inspiring and a bit makes you step back for a moment and say, wow, what are we taking on? Do you see the document growing? Do you see the appendices as a way that you'll add information without undermining principles? What's the future of this document over time?
Yeah, I definitely think the appendices will evolve over time. That's a place where we can provide concrete and very specific examples and case studies, and to the extent that those are useful, I certainly expect that content will grow. One of the other concepts that we really embrace throughout the roadmap that is probably worth emphasizing is this notion of learning and applying our lessons to improve. And so you'll find at the beginning of the roadmap, we actually talk about updating the roadmap on a regular basis on a 2-year cycle. And that's in part because we think things will change. Well, we know many things will change. We want those things to change based on the application of our lessons, so we're changing in a positive direction. And so the short answer is yes. We think things will evolve, and our intention is that we will evolve in a positive direction based on the application of our learning, and we'll do that as a collective community.
Well, Erica, this has been really helpful, but a lot of people are have some more interesting questions than I do. I've got two. Everybody heard the dings. I've got 2 questions up right now, but I will read them off. I will start with some of the questions, and I would invite anyone else who's watching this chat to start pushing the questions into us right now, and I will try to make sure we get to them. I will keep these private, so if you feel like you want to ask a question that you're not sure you want that to be heard, I will keep the names of the companies who's asking to myself here. The first question is, we've kind of touched on this, but I think it's a great question. The plan's principles of interoperability highlight, quote, building upon existing health IT infrastructure. But much of the existing health IT infrastructure was architected on principles counter to the interoperability roadmap's goals. While I understand the need to leverage infrastructure we have, shouldn't there be a stronger emphasis on the adoption/implementation of new technologies that can bridge the gaps as opposed to the older? I think you touched on that a little bit, but I think the questioner here is really getting on something really important, which is where do we in the technology industry place that emphasis, and how are you our partner to make that happen? Because if it's strictly propping up the old, I don't know that we'll get the level of change that you're hoping for. So talk to us a little bit about how you want us to help and how you're going to help us to make sure that balance is right.
Yeah. This is one of the, I talked a little bit about why that principle is in the roadmap, and a little bit about this push that we're making in the roadmap around RESTful APIs. Part of what we're thinking in this transition to an environment where technology developers are leveraging not just standard APIs but making those open is that it will promulgate an entire ecosystem of tools that then build out additional opportunities and functionality based on those APIs in a way that has not been possible in the past.
So you're seeing opportunities for companies not just strictly to do in-service product or in-user product, whether that be a patient or a caregiver, but you're hoping to encourage the creation of new tools.
That's absolutely right. That's absolutely right.
And so you see we went through a lot of that as companies tried to figure out how health information exchanges would work, and those have not quite panned out. So I do see this roadmap as something that's trying to answer some of the challenges that we faced in HEIEs. You want to touch? I don't know if you want to, but that seemed like something that you kind of recognized and said, okay, how are we going to bridge that gap? Is that something you're hoping to achieve?
It is. It is, and it's something hopefully it comes through in the roadmap, and something we've tried to discuss fairly explicitly. We need to be thinking about flexibility as we think about interoperability. That's not only important to accommodate change over time, but it's important to accommodate this notion that, again, although it may be frustrating, not everybody's going to move at the same pace.
Right.
And different communities have different needs. If you think about users within the research community versus public health versus frontline care delivery, the tools that they're looking to leverage oftentimes need to be different. And some of the design features, in fact, need to vary. But the data may be the same.
Right, the backend data will be the same.
Yeah.
This is obviously, I agree, this is a place where we need improvements in UX and UI, and the backend data may be the same, but they don't need all the noise or the clutter in an interface for an emergency physician. Then, of course, we've got the liability stuff. So this will get very interesting, and we're looking for how ONC can help guide it. It's a great point, but this is a question that we hadn't talked about at all, and quite interesting, which is, I would like to know if they, ONC, have any influence on restricting charges for patients getting their medical records, especially since not all of the access to that information is in interoperable formats. This is a very interesting question we're hearing from a lot of folks, which is that building interoperability and interoperable systems can sometimes be stymied by charges that are being levied against you as a vendor trying to build an interoperable system. I'm not sure that's truly ONC's space, but what do you think of that? Where do we go? How do you see that as part of the roadmap?
Yeah, it is a challenge that we hear about quite a bit also, not only from an individual's access to their own health information perspective, but from a provider's perspective also, just the cost of interfaces and bridging tools. It's a little bit, in some respects, actually in many respects, outside the purview of ONC. I think there are probably two approaches generally that can address that. One is price controls, right?
Mm-hmm.
Governmental price controls, which are not it's not within the authority of ONC, and I haven't heard that on the table for anyone else at this point in time. The other is to really think about how we create an environment where there's increased competition.
Right.
And then we lower the barrier to change. And when there's an increase in competition and an easier opportunity to select alternatives, we tend to see the cost of many of those tools go down. So
if a company is facing a problem where they're trying to do EHR interoperability and they're finding the growth and difficulty in terms of these kinds of problems, who should they write? Who do they send a message to? Maybe that problem isn't solved immediately, but who is collecting the information on that? And so it might become something down the road.
Yeah.
You said it's not really ONC. Is it OCR? Is it the secretary, HHS secretary? Where do you see that? Who do you think that information should go to?
Yeah, when it comes to the price of an individual accessing their own health information, that's certainly something to send to the Office for Civil Rights. That falls within the umbrella of HIPAA. When it comes to questions about costs of interfaces, many of those come to ONC. We do collect and track those. So that's certainly one venue to send it to. You can send it to the secretary. Honestly, I would encourage people to also think about sharing that information with their Congress people.
I would agree. And of course, feel free to send it to us. As ONC can tell you, we're not afraid to ask tough questions from time to time as well. I think that's a really good point, because I think ultimately, this is one of those times where sunlight is a good disinfectant, and I think we will a combination of competition and people being aware of what's in the playing field will hopefully lead to that. One more question, and I think we're getting close to the end here. Maya, if you've got others, send them my way. Oh, and this gets to our patient-mediated exchanges. I would like to know what ONC is planning to do to encourage patient-mediated exchanges, and how they're going to do a job of encouraging providers to include patients. Okay, that gets into patient advocate side. So let's break that into two chunks. Talk a little bit about patient-mediated exchanges, and then let's talk a little bit, I think we kind of hit on it, but I think talk to us about the role of healthcare providers including patients in this, and if that's OCR strictly, I think that's something that the audience should know. But talk to me about patient-mediated exchanges.
Sure, and the roadmap actually deals with this in several different sections. There's an entire section dedicated to individuals as engaged partners in their health. There's an entire section also devoted to providers partnering with patients to deliver high-quality care. A number of different calls to action to different communities to support this notion of consumer-mediated exchange. Or I would even encourage folks to start thinking about consumers not just as the passers of information, but the aggregators and users of information. I talked at the very beginning about making information, health information, the stuff of everyday decision making. We have calls to action in the roadmap for providers to not just give consumers or patients access to their health information when they ask for it, but to do that as a matter of practice proactively. Providers, there's actually room for providers to engage their patients in a conversation about the importance of health information and to proactively say, hey, you have access to this, let me give it to you, which is a very different paradigm than I think we have operated under for a long time. The framework for individual access to health information is something that is governed by the Office for Civil Rights, and so that, at least that federal framework, is something that sits in their space. But we do think a lot about, within ONC, how do we work with the technology community, how do we work with providers, and again, pointing to some of the digital health literacy stuff that we have in the roadmap, how do we work with consumers kind of across all of those different segments of the community to really advance, again, not just individual access to information, but actual use of it, putting it to good use.
Well, I think that's incredibly valuable. Maya, do you have any specific questions or more for us? And if not, then Erica and I can do our wrap-ups. But Maya?
No, I think you guys go ahead, and if you have any final thoughts, I don't see any more questions on any of the mediums by which we've been accepting them. So feel free to share any parting words, I guess, for the community.
All right. Erica, I'll let you go first.
Okay, great. I would just encourage folks, particularly the entrepreneur community, the app community, folks who are really advanced in the technology space, to keep an eye on the advancements that are made around EHRs and this notion of APIs, RESTful APIs, and to really pounce on that when those are available. There are several activities underway, not only through the S&I framework that I mentioned, but also through other standards development organization efforts like the Argonaut Project. Some of you may have heard of that, that will be producing standard APIs that we anticipate being implemented and made available, and it would be, I think, really tremendous to have a community of folks who leverage those and show us what's possible and really lead the way around the development of tools and applications. So an invitation, please, to the community to think about that. And then just a thank you for the opportunity to have the conversation about the roadmap today with you, Morgan, and with other folks who have dialed in. It's always a great honor for ONC to be able to participate in these things. So thank you for that, and look forward to comments on the roadmap.
Excellent. Well, thank you, Erica, very much. And I would say, I would echo what Erica said in the sense that those of you who are making the kinds of change products, the ones that are having patient impact or physician impact or care team impact, the ones that when you show off to your friends and family and they say, why isn't this in a hospital today? Let us know about those. You can reach me at actonline.org through our Connected Health initiative, which is at healthismobile.com, and feel free to email us. And this is something where we go to ONC and we demo products. Maya has seen me come and sit down and demo game-changing products for HHS for an opportunity to really talk about it. Because what we find is, here in Washington, D.C., there is a habit that we all end up in, which is we miss that change that you're making in Ohio or in Indiana or in Michigan, maybe even in Silicon Valley. There's a company or two there. But the goal is to make sure that we hear you in Washington, and so that we have a chance to really talk about how roadmaps, how policymakers, how the institutions that drive, frankly, the payment and reimbursement for a lot of these products, they understand the benefit that it will provide, both financially, but most importantly, to the patient. And so with that, I encourage you to reach out to us, to join in the effort to improve your healthcare system, and because everyone uses it, and really be a part of it. Feel free to reach us at ACT through healthismobile.com and through Reach ONC, through healthit.gov. And Maya, why don't you finish up with the last bit of housekeeping, give them the links that they need, and let's see if we can get in some great comments on the roadmap by the first of the month. And on this Hangout itself, if you have additional questions, Maya will tell you where to get them.
Great, thanks so much. I just want to thank you both for sharing your insights today on this extremely important topic of health IT interoperability. And thank you to everybody who joined the Hangout today for participating and being part of this process. I just want to let you guys know the full recording from today's discussion is going to be available both on this page and also on YouTube, so please feel free to share the link, distribute widely. And don't forget to submit comments, like Morgan said, on the roadmap to ONC by April 3rd at 5 p.m. So thanks again, and see you next time.